please. Good morning, ladies, gentlemen, teachers, and fellow sports physicians. My name is Chavithorn Ongkanchana. It is my pleasure and honor to be here today thanks to the TOSSM and JSOA and my senior colleague, Dr. Thongchai. Today, I'm going to tell you all about the role of conservative treatment in medial side injury of the knee. The main questions on today's topics will be on who and why conservative treatment is selected for. I hope after the lecture, you all will know who is the treatment is for and who should not be treated by it. After reviewing recent literatures, I found out that to determine the candidates suitable for a conservative treatment, we have to consider mainly two factors. The first one is the timing, and the second one is the characteristic of an injury. Timing of the injury is the first screening stage for the candidate. Conservative treatment goal is to let the MCL, which has abundant blood supply, heal itself. However, we should know that the environment for self-healing does not stay forever. After about 6 weeks, the forming of fibrosis and scar tissue will start to interfere with the healing potential of the MCL. Therefore, the optimal timing for treatment should be within 6 weeks after the injury. Next is the characteristics of the injury, which I will divide into isolated MCL injury and the multi-ligaments injury. For an isolated MCL injury, most of injury can be treated conservatively, in exception of first, the bony avulsion, and the second, the distal MCL entrapment, either by the pes inservinus or the tibio-femoral joint. Grading for the isolated MCL injury is still used up to this day. The first being AMA classification, which grading the MCL by the amount of valgus gap in 30-degree knee flexion, followed by Houston classification, which help reduce the ambiguous between grade 2 and grade 3 by dividing the endpoint and subclassify the grade 3 injury into 3 subtypes according to the laxity of AMA classification. One of the oldest publications about conservative treatment of MCL was done by none other than Dr. Peter A. Andelicato. He published 4 studies which report all good to excellent results following the conservative treatment in grade 3 AMA or the complete tear MCL injury, even in high demand patients. But he also noted that the key to a successful non-operative treatment is to avoid patients with a concomitant cruciate ligament injury. In the past 2 decades, our understanding of the medial side of the knee has been improved greatly. More attention has been given to other medial structures which forming the PMC or the posterior medial corner, which consisting of the POL, the posterior capsule, the posterior horn of medial meniscus, the semimembranous expansion, and the oblique popliteal ligament. We also know that the posterior medial corner itself functions alongside with the MCL in creating the valgus and rotational stability. The POL acts as a valgus and rotational stabilizer in a full extension, while other ligaments act as a secondary stabilizer to the external rotational force. Therefore, patients who sustain PMC injury would have a positive valgus opening in both 0 and 30-degree knee flexions. This is even without the cruciate ligament injury. The knee would suffer from an excessive rotational of tibia, which reflect on the positive anteromedial scrotum drawer test and the positive dial test. Be careful though when interpreting the results from these tests, since the positive anteromedial scrotum drawer test can also be found in a patient with ACL injury, while the positive dial test can also be found in a patient with PLC injury. Since the physical examination still are quite subjective, in 2010, Dr. Rapat et al. Reported a result from their biomechanic cadaveric study showing a correlation between grade of medial knee injury and the contralateral difference in gapping of valgus straight radiograph. By increasing gap more than 9.8 millimeter in 20-degree knee flexion and 6.8 millimeter when knee at 0-degree flexion are found to be correlated with MCL and PMC injury. However, up to this day, the MRI is still the gold standard for diagnosis due to the detail of expansion and the location of the injury can be assessed via MRI. Now that we know more about the science of the PMC injury, let's take a look at recent study to determine whether we can treat them conservatively or not. In the Journal of Bone and Joint Surgery Reviews in 2017, Chin et al. Recommend surgical reconstruction in patients with isolated MCL and PMC injury. That's because of the rotational instability of the knee might result in a poor outcome if treated conservatively. In the Knee Surgery Sports Traumatology Arthroscopy Journal in 20 and 21, Kara et al. Conduct an international expert consensus for the PMC injury and found that only 40% agreement on the statement that said, quote, isolate complete rupture of the PMC can be treated conservatively and successfully with a range of motion brace, which meaning that more than half of the experts did not believe that conservative treatment is suitable for the isolated PMC injury. In another recent review published by the Journal of Intercourse in 2020, Figueroa et al., the author also in agreement with the surgical treatment for the PMC injury, but also note that even though the most recent literature advocate for the MCL with PMC injury, is it crucial to recognize that although recommendations are still lack of high level of evidence. To summarize, in case of isolated MCL or medial side knee injury alone, conservative treatment still has some role in all grades of the isolated SMCL injury, except in the sternal-like lesion and the bony avulsion. While for an isolated PMC injury, conservative treatment is not really recommended in recent literature, but still lack of the high-level evidence. That's all for the isolated injury. Now let's talk about the patient with multi-ligament injury of knee. Can MCL still be treated conservatively in that kind? Like in the isolated injury, grade 1 and grade 2 MCL injury can be treated conservatively even with the presence of other ligaments injury. In grade 3, however, the story is quite different. 3 treatment strategies have been proposed for this situation. The first one being to treat MCL conservatively while performing acute surgery for the other ligaments. This strategy has decreased in popularity recently due to the discordance of the rehabilitation protocol between the MCL and the reconstruct ligament. Therefore, this one is not really a good choice. The second one is to treat the MCL conservatively while perform the delayed surgery for all other ligaments. By giving MCL time to heal before doing the reconstruction, this strategy seems to help reduce the arthrofibrosis post-operatively. And the last one is to treat all ligament with a surgery in an acute setting. This strategy becoming more popular, and some recent systematic review showing an improvement of functional knee score comparing to the delayed surgery, but only a few. In the most recent meta-analysis, however, did not find any difference between the two latter strategies, but recommend that if the delayed surgery is chosen, then the evaluation of the MCL competency should be evaluated before the final reconstruction. If the MCL is still lax, then the reconstruction is done at the final surgery. Two of the arthroscopic signs of incompetent MCL are: first, the drive-through sign. The medial compartment of knee is easier to access with valgus straight as the 30-degree knee flexion, showing gap more than 1 centimeter. And the second is a high-riding medial meniscus sign, reflecting on an injury to the meniscotibial ligaments. A large gap can be found between the meniscus and the tibial plateau. However, in the case of PMC injury in multi-ligaments, up to this day, there has not been any evidence supporting the conservative treatment in this condition. Furthermore, most of the literature suggests that the surgical repair or reconstruction should always be the first choice. To summarize the second part, in patients with multi-ligament knee injury, conservative treatment still sees some role in an isolated MCL injury, but the re-evaluation must be done after the conservative treatment period is over. And the conservative treatment is not recommended in the case of MCL with PMC injury. Nowadays, there are so many treatment algorithms for MCL injury. This one is just an example from one of the most recent literature. Okay, to conclude the story so far, back to the question on who is a good candidate for the conservative treatment. First, the timing of injury must be acute or less than 6 weeks. The second, currently the role of conservative treatment is narrowing down to mostly isolate MCL injury without any bony avulsion or entrapment. The existing PMC injury is generally considered as an important factor to decide on the management, but studies on the matter are still limited. Okay, thank you for your attention.